everybody. This is Corey Hill. We'll be starting in just a minute for our webinar, so thank you for joining, and we'll start in just a minute. Hi all, this is Corey Hill. I work at the Partnership for People with Disabilities at Virginia Commonwealth University, and I want to welcome you to our March Talks on Tuesday. It's almost never Apraxia, Understanding Appropriate Diagnoses of Speech in Early Intervention. I am delighted to welcome Dr. Corey as our presenter today. Corey is the Associate Professor in the Department of Communication Sciences and Disorders and the Associate Dean of the College of Health and Human Services at Radford University. Beside all that good stuff, Corey is my longtime colleague and friend and a longtime friend to early intervention, and I know you guys are going to really enjoy her presentation. So welcome, Corey.
Thank you. Well, I want to thank all of you for participating today. I'm thrilled to be here. I have to tell you a few things about myself. It is my wedding anniversary, so yay for that. And that cutie patootie on the front slide of this presentation is my 10-month-old Susan. Isn't he a cutie? So I've learned a lot. I've been a speech-language pathologist for over 18 years now. I'm a new mom, so I've learned a lot about language and speech development over the years, and now I'm experiencing it even more firsthand than ever before, and wow, it is here. I do want to apologize. I'm getting over a cold. I'm sure 99% of you can relate to this, and so I apologize for my froggy throat, and if I cough once in a while again, hang in there with me, and I promise we'll get through this. But again, I do want to thank you. I know it's been a busy time with all of this snow, and it's great that you were all able to join us today. So I'm going to jump right in. Today we're going to review typical development of speech sounds and phonological patterns in infants and toddlers. So we're going to focus on infants and toddlers today. I'll address the differences between articulation and phonological speech, which I know is a hot topic for everyone, and organic speech disorders, as well as what to expect in regard to differential diagnosis of these disorders with children under the age of 3 years. I'll also share information about what is and is not appropriate in regard to diagnoses. So throughout today's session, I may be addressing some ideas that are new to you, or that come from a perspective that is different than the one from which you have been working. I want to assure you that while all of the information that I will be providing to you today is evidence-based, some of it has been a work in progress for me to implement as well. We've come a long way in the field of speech and language development, and our knowledge about speech sound disorders has expanded tremendously even just over the past 10 to 15 years. We now have a lot of strong evidence that did not exist when I first entered into the field and in my first few years in early intervention. So I ask that you all keep an open mind and feel free to ask those questions as well. Okay, so to ensure that you will enjoy and learn from today, you're going to need a few things. You're going to need something to write with. Anything will do. Some of you might have a spare crayon in your drawer. Go ahead and grab that. Something to write on, preferably on material that you can read when you write with that crayon, and your own ideas and questions to share with me and with each other. Okay, so let's get started with a few basic definitions and concepts just to ensure that we're all on the same page. So I'm going to start with articulation. Many of you know all about articulation, and so again, this is just a review, so stick with me here. Articulation is the process of producing or making speech sounds. So for example, children must learn how to produce the R sound in order to say rabbit instead of wabbit. Believe it or not, children begin to develop these skills at birth. Of course, babies are not born talking, we all know that. It's the first step in learning how to produce speech sounds, which in turn will become meaningful words, phrases, and sentences. So this is the first point at which I want you all to jump in. Think about this for a minute and consider my question on the screen. Take a look at the choices and put a sunburst, or another kind of a mark if it fancies you, on the age by which you think typically developing children learn the sounds of their native language. As I mentioned, this process begins at birth, but I'm referring to the age by which a child has been exposed to and has learned all of the sounds by hearing them in their environment. So go ahead and find the toolbar to the left of the slide on your screen. Some of you are beginning to do so. Click in the box that looks like a little sun, and then click on the percentage range of your or the number of your choice to leave a sunburst or other mark. Ooh, I see a smiley face. We'll see which number has the most sunbursts to see what you all think. So I'm going to give you about 20 seconds. All right, so before I give you the correct response, go ahead and, for those of you who haven't done it yet, click on that sunburst or that little mark to the left of the screen and pick which month you think is the age by which typically developing children learn the sounds of their native language. Okay, so I see a few participants have joined in here. So typically developing children learn the sounds of their native language by 9 months of age. So the majority of you have gotten this correct. This does by hearing them, and that they're starting to get them all organized in their amazing little brains. So when those oral motor skills are developed enough, they can actually begin producing them. So that's our start. That's our foundation. So what is typical in regard to articulation development and children's production of these sounds? When should children master the production of all of the speech sounds? And in particular, what should we expect from infants and toddlers in regard to their articulation development? Well, there have been a lot of evidence-based studies, multiple evidence-based studies conducted over the past 75 years in regard to just this. The table on this slide, which has also been provided to you in a handout prior to this talk, so hopefully most of you have this handout available, presents the most frequently used range of expectations by which all speech sounds should be accurately articulated by young children. Now keep in mind that all children will not necessarily, children begin to develop that in their very first year, but for some children it takes them until the end of their 3rd year, until they're almost 4, to be able to articulate it or produce it accurately. So again, all children will not necessarily learn the sounds in the same order, but there is a sequence that we expect, and this is what you're looking at right now and that you have on your handout. Okay, so based on the developmental expectations that I've presented in the previous slide and on your handout, we don't expect a toddler to produce all sounds accurately. I think we can all see that and agree upon that. So let's practice our knowledge using the table that was on the previous slide and in your handout. Using the poll feature, answer the following yes/no question. Yes or no, would we expect a 2-year-old, a 24-month-old, to accurately say the K or the K sound? Yes or no? What do you all think? Go ahead and click on that poll feature and let us know. Yes or no, should a 2-year-old be accurately producing the K sound?
And this is Corey Hill if you just joined us and are looking for your poll feature. As a reminder, it's right under your name. There's probably either a little check or an A, and in the corner there's a drop-down feature so you can participate in the polling. Thank you.
So again, while you're all thinking about that question, I see that I have a request to talk a little bit slower. Believe me, this is a request I get from my students all the time, so I will definitely give it a shot. And I appreciate you letting me know. It's hard for me to monitor that feed for myself. All right, 10 more seconds. Yes or no, does a 2-year-old, do we expect a 2-year-old to accurately say the K or the K as in cat sound? All right, Corey is supporting me here. She's saying that's the northern in me, my fast talking. I am originally from Connecticut, and I moved here 8 years ago, though, from Boston. So yes, it does get in the way at times. But okay, so I'm taking a look at so 48% of you have said no, a 2-year-old should not. 5% have said yes, and 45% of you are still unsure. So the answer is, based on developmental expectations, no. A typically developing child will often produce a T or a T in place of a K or a K until she's at least 3 years old. Some children will even delete the sound entirely until close to 3 years old. So instead of kitty cat, you'll hear a child often saying titty tat. Okay, Jeannie's going to clear the poll now, and we're going to try another one. Would we expect a 3-year-old thank you, Jeannie, a 3-year-old to accurately produce the R sound, R as in rabbit? Yes or no? So again, feel free to use the table in your handout, if you've got that available. If not, take a guess. Do we expect a 3-year-old to accurately produce the R sound? We'll take just about 20 to 30 seconds to give you all a chance to answer that. Responses. Okay, great. So of the people who participated, you've all said that the answer is no. And again, that's correct. Based on that table, which is, again, evidence-based, we've got all the literature and the data to support it, we can see that a typically developing child will not accurately produce the R sound until at least 4 years of age. And for some children, that range may be 7 or 8 years before they truly master this tough sound. Usually, children will substitute or distort sounds while they're learning to accurately produce them. So for example, a young child will produce the T for K as in tat for cat, or the W for the R as in wabbit for rabbit, or gween for green when they're toddlers and even preschoolers. And it is in fact quite rare for children to develop speech without producing lots of errors throughout the process. These types of age-appropriate errors are referred to as developmental errors. And this just means that they're typical age-appropriate errors and that the child does not need speech therapy or specific intervention to address them. Articulation. Excuse me. When should we get involved? Typically, a speech-language pathologist and SLP, like myself, will diagnose an articulation disorder if a child is demonstrating a delay of at least 6 to 12 months in regard to the production of certain sounds, based on the age at which mastery of the sounds is expected. So if that K and G sound are expected to be mastered by the age of 4 years, a child should not be differentially diagnosed with an articulation disorder characterized by errors of these sounds until the child is at least 4.5 years old. Ultimately, what does that mean for us? This means that an infant or toddler really should not be diagnosed with an articulation disorder at all. Since the earliest sounds, including the P, M, H, N, and W, as you can see on that table, are not expected to be mastered until the age of 3 years, a child between the ages of birth to 3 years old is not yet expected to produce any sounds correctly. Okay, so then that's one element. But then what about phonology? A child's speech development is not just about his or her articulation skills. Now, for those SLPs on the line, I know that phonological development falls under a language category technically, but for purposes of speech sound development, we're going to talk about it under the guise of under speech. So when SLPs are assessing a child's speech, we're typically also looking at sound pattern processes. Now, phonology is the study of how speech sounds, which are also called phonemes, are organized and used in a language. So I won't refer to phonemes too often, but that's how we talk about speech sounds in our field. And this includes the study of those individual sounds of a language, the phonemes, their patterns, how they're learned, which is called phonological development, and how they work and go together. All right, so now I'm going to give you a little bit of a tutorial here about how we categorize phonological development. And I'm just warning you because I'm going to be using the pointer tool and I'm not very good at it. So bear with me, let's see if I can get this to work. So all the sounds in the English language, and we're going to focus on English for the purposes of today's session, are organized and classified into different classes based on their place, their voice, and their manner. So by place, let's see if I can do this here. Oops, a minute. Here we go. By place, I'm talking about the location in the oral cavity, in the area in and around the mouth, where the sound is actually produced. It's produced between the lips, right? So if you all say you see that you close your lips and pop out the sound. And so that place is between the lips. It's considered a bilabial because it's between our lips. A D sound is produced in the front of the oral cavity with the tongue pushed up against the hard palate. So again, everybody silently or out loud, go ahead and give a good duh sound. And your tongue is pushed up here behind your teeth against the hard palate. Another example is the G sound, the G. A G sound is produced in the back of the oral cavity, right up back here, if you could see with my pointer, with the back of the tongue pushed up against the soft palate. So again, everybody give a good ga, goo goo gaga. And you can feel that your tongue is pushed up toward the little uvula dangling back there. It's pushed up in the back. And so we consider that place, the place by which your oral cavity is actually producing the sound. Now when we talk about voice, I mean whether you actually use voice to produce a sound. So when we say ba or ga or even da, we use our voice. When we say pa or k or t, another component that we consider. And then finally we consider manner. Manner indicates the way in which the air is pushed through the vocal tract and the degree or type of closure of the vocal tract when we produce the sound. So for example, when we produce an S, as in snake sound, we push the air, everybody make a S, we push the air between our teeth and our lips. And in contrast, when we produce a P sound or a P sound, we pop it out from between our lips. And finally, another example is an R sound as in rabbit, not an R sound, an M sound as in mama. Those sounds we actually produce the air through our noses. So everybody just give a good mmm. You notice that your mouth is closed and the air is coming out through your nose. So that's thank you, Corey, for giving us a little finger there pointing. So that's our little nasal sound, we call it. Okay? So those are the three parameters that speech pathologists consider when determining whether a child is demonstrating typical patterns of speech. Okay, so therefore when we refer to actual phonological processes, we're talking about the typical patterns that a child uses. If a child is learning to speak English, he or she will simplify those sounds and those sound patterns. So for example, a young child will simplify the word bottle to sound more like baba. A toddler might say goggy for doggy or nail for snail. We might hear a 2-year-old cut off the final consonants of words as they work through new vocabulary. Please might become P, and ball might be produced as ba, where they cut off the final L sound. Just as with articulation, every child will develop their phonological skills differently. And just as typically developing children will develop their articulation skills within those expected age ranges that I presented, there are ages when children are also expected to stop using these different phonological processes. So what should we expect in regard to typical phonological development? We also have milestones for these, and we know that there are expectations for infants and toddlers in regard to these phonological processes as well. So if you take a look at the screen, you can see that I have a table up here, and we're going to go through some of these processes and these examples. And again, so as you can see from the table on this slide, there are quite a few processes that we SLPs monitor and that we expect our infants and toddlers to use. We expect them to make these processing errors. Some of the most commonly observed with the youngest of children who we see, and I'm going to try to point to some of these again, are final consonant deletion, and I mentioned this as an example. So final consonant deletion is when a child deletes the final sounds of their words. Co for comb, da for dog. And we hear that a lot with really young children. It's one of the most common. Another common process is fronting. And so here you can see an example of fronting. Fronting is when a toddler substitutes a sound that we produce in the back of our oral cavity, like ka in car, for a sound that we typically produce in the front of our oral cavity. So they put their tongue up in the front instead of putting their tongue up in the back. So they get tar for car. Another common one is gliding. And gliding is a process that a child uses where they produce a W sound instead of an L or an R sound. Toddlers also tend to use a process called stopping, and if you look here you can see lots of different examples of stopping. And this refers to the substitution of sounds that we typically slide through our teeth and lips, so if you think of the manner by which we produce these sounds, and to use instead sounds that pop through our teeth or lips. So for example, a child might say dope instead of soap, or do for zoo. Okay, so honestly I have to guess that you probably recognize most of these processes, not by name, but by the children with whom you work. They're probably using a lot of these every day, all the time for those who are talking. So let's take a minute to look over the table, which you also have in your handout, and to think about the processes that you've heard the children with whom you work use. Now I see some of you have already jumped in here with the question or with the request that I put on the screen here to share an example. So I want you to take a few more seconds, and people, I'd love to hear what you have to say, and share a few examples of words that you've heard your kiddos use where they've deleted that final consonant. I already see 2 examples, pa for pop and how for house. 1 or 2 examples of this common yet developmentally appropriate pattern. So let's see, ka for cup, great. Anybody else? What else can you guys think of? Great. I see some of them coming on up, and I'm sure you guys can all see those as well. P for please, piff for pig, da for dad. Great. A very common one, P for please. Our parents just love kids to say please, don't they? It's one of those words that they can't really say because of all these articulation and phonological developmentally appropriate issues, but yet they love to have them say it. Okay, so you guys are welcome to keep those coming, but as you can imagine, and most of you have clearly experienced, in addition to developmental articulation errors, these processes often wreak havoc on our ability to understand what children are saying. And yet, the question remains, should we be concerned when working with children under the age of 3 years? All right, well the answer is not really. Not entirely, but not really. A phonological delay or disorder refers to when a child can severe phonological disorder may even simplify their speech to the point where they're only producing a few different sounds when they should be producing a variety of sounds and combinations. Children with true phonological disorders tend to be extremely hard to understand, above and beyond typical expectations, and we're actually going to talk about those expectations in just a few minutes. If you think back to the table on the previous slide and in your handout, however, most of the processes that we monitor are still expected to be in a child's repertoire until at least the age of 3. Now, with that said, there are a few red flags that a young child under the age of 3 might demonstrate where we are concerned about a future phonological disorder. So I've put those up on the screen here for you. Let's talk for just a minute about them. The big 3 are the deletion of initial sounds in words. So for example, ig for pig or ed for bed is one of those flags. So we don't typically see that with kids. And if you go back to that table, you'll notice that's not really one that's listed on there. So initial consonant deletions are not a process that we expect to hear toddlers using. So that's a flag. Another major concern at an early age is the distortion of or consistent difficulty with vowels. Vowels are one of those tricky things. Vowels are actually produced fairly naturally for most kids. They imitate them in their babbling. They practice them in their quiet times. And definitely another one of those red flags that sort of piques our interest and gets us thinking about things. And finally, if a child deletes sounds altogether, lots of sounds. So these again are kids who are trying to talk, who want to talk, are attempting to communicate, maybe even 2-2.5-year-olds who are putting together little sentences, but they're deleting lots and lots of sounds in those sentences. We certainly might be concerned enough to monitor or encourage the production of those missing sounds specifically to see whether they are stimulable to produce those. The bottom line, though, is that it's not typical to diagnose a child with a phonological disorder before the age of 3. And again, since most of the processes that we monitor are expected to be present, these processes that come across as errors, they're expected to be present in a child's verbalizations until the age of 3 or older. We really just want to monitor the patterns in a child's words and phrases until they're 3 years old. Okay. So excuse me. So now that we've reviewed articulation and phonological development and disorders, I promise that we come back to expectations regarding intelligibility. So let's consider what this means. As an SLP, I often hear from parents, from caregivers, even from early interventionists, my colleagues here at work, that their children are really difficult to understand. And the question that is often posed, well, since we've now established a clear understanding of the time and the expectations that are involved in speech sound and phonological development, We also know that it's clear we very well may have difficulty understanding that child with whom we work and play, and that honestly some of that difficulty is to be expected. So throughout infancy, toddlerhood, and the preschool years, children are continuously improving upon the clarity and accuracy of their speech sound productions. Those pesky phonological processes are still working their way through a child's verbalization, and those are some serious developmental hurdles to intelligibility. Now I'm going to jump over here to chat. I see that there's a question. Is backing also considered a red flag for children under 3 for phonological disorders? That's a really good question. Backing is an atypical pattern, but typically if a child is demonstrating backing, I often think they're kind of ahead of the game. I mean, unless they're doing it for everything, and sometimes we see that children will collapse. You know, if they're making a ga or a ka sound, and that's what this person is asking really, to do what we call backing is to make the sound in the back instead of in the other parts of the mouth. So if the child is using gas and kas and is not using any other sound, but is really communicating well on a language level, then yes, we would be concerned. But if the child is just developing his or her language, and they tend to 3. So it just depends too on the context of language, and we're going to talk a little bit more about that as well today. I hope I answered that question, but if not, let me know and feel free to post it again for me. Okay, so back to intelligibility for just a few minutes. The term intelligibility refers to speech clarity, or the percentage of a speaker's output that a listener can readily understand. So in typical development, as children learn to talk, their intelligibility, which again is how clear their speech is to those around them, steadily increases. In young children, there's often a marked difference between the intelligibility of single word productions and conversational speech. So it might be much easier to hear one word than it is to hear to understand one word than it is to understand a child who's using multiple words in a more conversational context. There also might be a difference in intelligibility when the child is talking about or in a known context versus in regard to unknown or novel topics. So if a child comes to you and just starts talking about something that has nothing to do with what you were playing or engaging in, it's going to be much more difficult to understand that child than if that child is talking about the cars that you've been playing with for the past few minutes. And even within families, we sometimes see and hear that siblings are more adept than parents. Are older siblings actually understanding them, or are they actually just pretending to understand them? And really, sometimes we might never know. Regardless of the different conversational partners and contexts, however, we do have some basic expectations for children in regard to intelligibility as well. We typically consider these expectations in terms of percentages. So by 5 years of age, for example, a child is expected to be 100% intelligible. Now if you think back to the articulation and phonological development, a 5-year-old is not expected to have perfect articulation or even have gotten rid of all of those phonological processes. Even though some speech differences are still likely to be present, however, his or her speech is expected to be clear enough so that everyone who engages in conversation with that 5-year-old child, including unfamiliar listeners, is able to understand 100% of the child's verbal productions. All right, but what about the younger children with whom we interact and work? So I want to know what you all think. When we think about percentages and ranges, think about this for a minute. So look at the choices above, and I want you to go ahead and put that sunburst or your symbol on the picture by the percentage that you believe is the correct answer. So by the time a child is 2 years old or 24 months, what percentage of his or her speech is expected, should we expect, to be intelligible to an unfamiliar? If you guys want, I'm going to give you a hint. This information is on your handout. So feel free to look really, really smart and look that up before you go ahead and put your symbol on here. But either way, which one do you guys think? Okay, so I'm seeing a consensus here. Although there's one little outlier, then would be intelligible. And you would be correct. Correct. So we're going to come back to this in just a minute, but I want to go ahead and ask you the next one. How about a 3-year-old then? So we're talking about kids birth to 3, but how about a 3-year-old? How intelligible should we then expect our 3-year-olds to be, or our kids who are moving into that transition phase? What percentage of intelligibility would we expect? Great. I'm definitely seeing a pattern here, or I think you guys are seeing the pattern. A 3-year-old is then expected to be between 51 to 75% intelligible. Let's do one more. I think you probably can all guess now if you don't know. All right, I think I'm losing people because you just are making the assumption that we all know now. So a 4-year-old, as you guys are correct, who did participate, all of a sudden lots of people, a 4-year-old is expected to be 76 to 99% intelligible. That's correct. And as I mentioned a few minutes ago, we should understand based on evidence that we have in the literature, and some of that evidence has been presented to you guys on the handout, and I'm happy to share additional evidence as well. But these are the ranges that speech-language pathologists often use when we're screening the children. So as you can see, a young child's intelligibility, again, how much we understand of his or her verbal message. It takes time for children to develop their articulation of all those speech sounds. It takes time for children to decrease those phonological processes. We will not understand everything that they say for a while. And although it's frustrating for the children and often more frustrating for the families, we should not expect to do so until a child is at least 4 years old. Little ones are producing speech that we can understand within these expected parameters. Okay, so now that we have established expectations in regard to articulation, phonology, and intelligibility, I thought I'd give you a little information from my perspective as an SLP, how we actually assess speech sound development in early intervention. So we know these parameters. The answer is actually quite simple. And it's simple because all of you who are participating today have been doing the same things that we're doing. We're just looking at the child within specific parameters. So SLPs will engage and interact with an infant or a toddler through play, just as we would to obtain a language sample. We will be listening for the sounds and the patterns that the child is using, and will monitor his or her articulation and phonological development. We'll ask the families, how much do you understand your child? Is he impossible to understand? Do you understand him half the time? And ask those types of questions to get their feedback. Based on our observations on the expectations that were just presented to you, we will listen for those atypical phonological patterns, including initial consonant deletions and vowel distortions, to determine whether phonology is an area we're all still developing throughout the infant and toddler years. And the role of intelligibility? Well, again, since we know that children are going to be difficult to understand prior to the age of 4 years, an SLP will also determine just how unintelligible a child is, or how intelligible a child is at any given point in time. Excuse me. So if a child is less than 25%, or a parent reports that he or she understands that 2-year-old less than a quarter of the time, or a 3-year-old less than half the time, we should be concerned about the child's speech. There may be something going on. And other than that, it's important to keep in mind that a 2 or 3-year-old is going to be difficult to understand, and often. Now I want to point something out. I was trying to think of questions that you all might have, because I know from my experiences of all these years, a lot of our kids are 2, 2.5, closing in on 3, and they're just not talking that much. That's a problem with the language and communication. So when we're looking at speech, it's important for us to remember that we can't assess speech development, including articulation or phonological development, until they start talking and that we see what they're doing with their language. The speech is going to be embedded in the language. So that it's for even assessing speech, because they're not using it within the language itself. We first need to help them communicate before we can start assessing their speech. Okay. So what should we expect in regard to diagnosis prior to the age of 3? Now, based on the information that I've provided today, what are your thoughts? I want you guys to go ahead. If you're in a group, I know a lot of people are sitting around the computer or around the phone now listening to me. Talk about and let us know what you think as well. So what should we expect? I see people are beginning to respond. So D says expressive language diagnosis with regard to a speech issue. Okay, so yeah, so I think what you guys is the child attempting to make sound. So good. So I think you guys are on the right track. So expressive language, perhaps even their receptive language. Should we be diagnosing them with an articulation or phonological disorder? I know that's more of a yes/no question, but just to make sure we're all on the same page. You're absolutely right though. No, yeah, not yet, exactly. So yeah, we're looking at their language and their communication. If they are talking a lot, should we be looking at the speech and language, should we be looking at articulation and phonological development as an area of concern yet? I want you guys to continue to talk about this. But by now I think we've established that a child under the age of 3 years old will typically not be diagnosed with an articulation delay or disorder or a phonological processing disorder, unless we see some major red flags, and again, that includes consistent vowel distortions or difficulties, deletion of initial consonants, or the deletion of so many sounds in a talker that the child's hardly using any consonants, then we really should not be diagnosing an infant or toddler with an articulation or phonological disorder. They are still developing. And again, why is that? Can anyone tell us on the chat line why we should not be diagnosing infants and toddlers with articulation or phonological disorders? Here's the question for you guys, but why should we not be doing this yet? They still have time to develop. Yeah, processes are still developing, absolutely. Because many sounds are still in the process. Thank you, Allison and Kay Hansen, that's great. Yeah, so it's just not age appropriate. That's exactly right, developmentally or age appropriate. Now, Dina asked how do we handle this if a colleague considers this an okay diagnosis. I think, we all need to be appropriate and professional with our colleagues, and I think we're seeing a lot of this, which is why this is a topic that we're talking about, that we're going to be providing to you even after this session. You can ask them to get on the archive and to listen to what I have to say, and we're going to be doing some further presentations and discussions about this in the next few months, and I'll give you more information about that. Send them our way though. I'm happy to talk with people personally, but I think this is what we're trying to do now. We're trying to educate the families. Kay, I don't know what Kay's first name is, so Kay Hansen has, what about parents who are overly concerned? And I can answer that personally and professionally, that I've experienced that a lot. I do early intervention. As I can tell you, we get a lot of high maintenance, great invested parents who are advocating for their kids, and the information that I'm giving you today is the information that I give them. I say, we don't want to get too much into charts and tables, but when we talk about developmental expectations, those are the things that parents need to understand and need to see in order to recognize that their child is doing okay. Do I consider speech sound repertoire when determining atypical speech? Well, I do consider that, but again, if you go back to that articulation developmental chart, Fairfax folks, you'll see that all of those might be distorted, and it's okay at that age unless you see those red flags. So we look at that, but we're monitoring it to a certain extent. Is there a sense of how many words children by 2 and 3 should be using? Absolutely there is. That's an entirely different topic though, because again, and I'm glad you brought this back to us, again we're talking about language then. If we're starting to talk about words children should be using at different ages, we're talking about language. And that's the key thing, that is what we should be looking at while we monitor speech development. We should be focusing on their language and their communication skills. So again, I'm going to get they're still developing their speech sound production skills, and there are no sounds or processes that should be mastered by the age of 3. We need to be really cautious about diagnosing them with a speech-related disorder, because we know, as you've all said on here so beautifully, we have to be aware of it, but we don't want to diagnose something that's still developmentally appropriate. So here is the question though. Here is the question. Are there any situations in which we might address disordered speech sound development with infants and toddlers? And because I don't want you to think that this is an all or nothing situation. And now we've come to childhood apraxia of speech. And this is a huge hot topic. I don't think anybody would question that. So I'm guessing that many of you are now wondering, what about apraxia? You may have heard of it. Many of you have probably have kids on your caseloads who have been diagnosed with childhood apraxia of speech. I'm going to refer to it as simply apraxia from here on out. And I'm here to set the record straight on this one as well. Apraxia is an uncommon speech disorder in which a child has difficulty making accurate movements when speaking. It's important to know that apraxia has to learn how to make plans that tell his or her speech muscles how to move the lips, move the jaw and tongue in ways that result in accurate sounds and words. So in this case, the child's brain also plans these movements so that he or she speaks with normal speed and rhythm. Now in childhood apraxia of speech, the brain struggles to develop those plans for speech movement. And so as a result, children with apraxia do not learn accurate movements for speech with what we would consider normal ease. In apraxia, it's important to know that the speech muscles are not characteristics that we've determined that help distinguish apraxia from articulation and phonological disorders. Now, the characteristics that are particularly associated with apraxia include difficulty moving smoothly from one sound or syllable or word to another, groping movements with the jaw, lips, or tongue to make the correct movement for speech sounds, vowel distortions, which I've mentioned several times, such as attempting to use the correct vowel but saying it incorrectly, using the wrong stress in a word. So instead of saying the word syllable, you'd say syllable. Separation, bull, b. They're not quite stuttering, but they're having difficulty getting each syllable out. Inconsistency in making errors, so you ask a child to say something several times and each time it sounds a little bit different, even a simple word. And then just difficulty imitating those words. Now what I want to point out to you with all of those things on the list are that those are things that kids can only demonstrate if they're already talking. So if you have because they're not demonstrating those issues yet. They're not showing us that they're having difficulty with those specific things. But why are we so confused about this? Well, at one point in time, about 15 years ago, really within the first 5 years or so that I started to practice speech pathology, there was a widespread belief that if an infant or toddler was a late talker or was difficult to understand, he or she might have apraxia. The thing is that this has since been proven to be incorrect. That proves these connections to be completely incorrect. There are several characteristics that are seen in most children with language problems that are actually not specific to childhood apraxia of speech. But I think initially when we started hearing the word apraxia, we thought those things are the triggers. Those are the red flags. These things include reduced amount of babbling or vocal play or sounds from the ages of 7 to 12 months, speaking first words late after 18 months, using a limited number of consonants and vowels, are indicative of a late talker or a child with an expressive language disorder, or are developmentally appropriate in some cases if we're talking about intelligibility and phonological processes. So here's the bottom line. In fact, in order to differentially diagnose apraxia, a child must be at least 3 years old and be able to intentionally imitate multi-word utterances of increasing complexity. An infant or toddler is not even developmentally capable of imitating long sentences, let alone sentences that are complex in regard to vocabulary and grammar. Therefore, a diagnosis as an SLP, I have not actually seen an accurate diagnosis of a child with apraxia prior to the age of 4. And I want to share with you guys that this has been a process of evolution for me as well. You know, 15 years ago when we were all hearing about apraxia and a late talker must have apraxia, or a child who's having difficulty with words and sounds must have apraxia, I too jumped on that bandwagon. It just made sense. They're not talking, they have a diagnosis, we can get it reimbursed, let's go. But what I've learned over the years is that this is a very specific diagnosis that's often an inaccurate diagnosis. And we want to be really careful about that because it leads to an entirely different purpose and intervention than for a child who has a communication disorder or an expressive language disorder, where we really want to focus on functional language outcomes. Okay, so I know you probably have lots of questions or comments about that, but I am going to keep moving on because otherwise we're going to run out of time when considering the diagnosis of speech sound disorders in young children. Well, children with cerebral palsy often also have difficulty producing a variety of speech sounds. It often seems like these children struggle with the development of their articulation. When this is the case, however, it's often because of weakness, spasticity, or the inability to control the muscles in and around the oral cavity that allow them to produce speech. And this actually has a name. This is called dysarthria. So for a child with dysarthria, children with dysarthria may also have a hoarse, soft, or even strained voice. Might sound like mine does right now, but on a typical basis, or slurred or slow speech. Of course, it is important that we consider these issues and address them with the child and his or her family. We need to be aware of the weakness or the spasticity that the child's dealing with, and we need to address the inability to control the muscles that the child uses to produce speech. We may actually even need to consider augmentative or alternative communication options for our children with CP who struggle to put infants and toddlers to learn to obtain their needs and wants. All right, infants and toddlers with either a cleft lip or cleft palate or both also present specific challenges related to speech sound productions. And I want to address these here for just a minute. Before a child's palate repair, it will be difficult for him or her to learn to say sounds that require air pressure to build up in the mouth. Including sure, however, that these children hear these sounds frequently, since they're still learning these sounds and will eventually begin to use them after their surgeries. The main expressive goal before a palate repair, therefore, is to help the child learn to produce sounds by using his lips and tongue to create sounds. So I've got a little more information about that, and I'm going to go ahead and hold off on that. But again, that's a legitimate area in which we might need to address speech development. All right, so any organic causes, including speech sound disorders related to cleft lip and or palate, dysarthria related to cerebral palsy, or even delayed speech related to a hearing impairment, which is another talk for another day, are legitimate diagnoses related to speech. These issues relate to the coordination of muscle movement, as in the case of dysarthria, weakness of or damage to the oral structure, which would be related to cleft lip or palate, or lack of auditory. But what about developmental speech? Now I see there's a question from David talking about chronological age. And he says he's seen a number of bright, highly vocal toddlers who grope, have initial sound omissions, vowel distortions, for whom language therapy has been ineffective. Yes, so I can comment on that, David. You're talking about some of those big red flags. So if you do have highly vocal or verbal toddlers, who are those red flags that we talked about? And absolutely we'll want to get in early and work on those. But to be honest with you, we don't see that too often. Most of the time what we're working with are who we're working with are children who are not yet talking or not yet verbalizing to the extent that's expected. So you're absolutely right. We don't want to ignore that when we do see it. But those are very specific things that we're looking at for children who are already talking. So yeah, absolutely we don't want to ignore those kids. So when we talk about that, you said, we're talking about chronological age, and that's exactly what we're talking about. So I want to get back to that for just a minute. Because speech sounds are still developing and phonological processes are still expected in children under the age of 3, we should not be addressing articulation or phonology as a disorder unless, again, we see those red flags. Sure, you may be addressing speech sound development. To address it within vocabulary development is appropriate. So for example, if a child demonstrates limited language, and you decide that it's important with the family for that child to verbalize mama or more in her everyday activities, focusing on that M sound to make that outcome happen absolutely makes sense. All right, so we don't have a lot of time to talk about insurance, and you know what, we should. Targeting specific speech sounds in isolation before the age of 3 as a specific area of need does not make sense on a developmental level, which is exactly why the insurance companies often question it. Language, yes. If a child has a language disorder, that's another story. We should address the delay or disorder in language development. We should bill for the language-based disorders because they are, more often than not, the culprit for an infant or toddler who is having difficulty communicating. Okay, so what does this mean for us as early interventionists? Should we avoid incorporating speech sound play or production in our coaching? If we really care children who have difficulty producing sounds secondary to a neurological or organic disorder, or for those children who are demonstrating those major red flags, what role does speech have in our practice? Should we even be including speech sound development in outcomes for infants and toddlers? Well, I believe the answer is no and yes. We are constantly talking about the fact that sounds or imitating environmental sounds, we often see outcomes that are focused on the production of these types of sounds. And SLPs, including myself, have often gone in that direction because typically developing children pick up on those sounds with ease. I can tell you that personal experience, my 10-month-old is not verbalizing true words yet, but he is imitating animals. Children who are typically developing tend to imitate them. But here's the thing. When we're working with a child who's really struggling to get his or her basic needs or wants met because he doesn't have the language, teaching a child to produce a bunch of animal sounds is not really a functional choice. So a child learns to moo or meow, but does that really help him get a drink of milk or call his mom? I know we're running out of time, but think about this for just a minute. Is the family's goal for this child really to produce animal sounds? Or is it to imitate the sound of an airplane or a car engine or another environmental sound? Of course not. So let's go ahead and put this all together. When we work with young children who are struggling with language development, they certainly need to be able to obtain needs and wants by learning how to label desired objects or to make a verbal choice. These are functional outcomes. in order to request a drink or to ask for more, or to label the boots that a little boy wants to wear to play in the snow, which I think we can all say we've had enough of, but these kids still want more. He needs to be able to produce an Apraxia, therefore is not in itself to produce the M or the B sound specifically. The production of these sounds can and certainly should be embedded into the intervention itself. So where do we go from here? How do we embed speech sound development into our outcomes? And Dana's even said this is really something to think about, and I agree. It's something I think about a lot. How do we effectively incorporate speech? We are about out of time, but we certainly don't want to leave you hanging here. So here are the next steps. Over the next 8 weeks, I have been enticed to work with the Integrated Training Collaborative Professional Development Team to provide 4 blogs on their website. Now, blogging is a totally new thing for me. I've never done it before, so I hope that you'll all participate and respond to the blogs. I'd love your feedback and input as we go along during the May 5th talks on Tuesdays. So get online, read the blogs, respond to the blogs. I want to know what you guys are doing, what's working, what's not working, what concerns and questions you may have, so that when you register to join us again in May, we can all work together to address functional outcomes in early intervention that incorporates speech sound development of the infants and toddlers. We'll be presenting again in May, the second one on May 5th of the Talks for Tuesday. So make sure that you get ready and register. I think Corey Hill's going to be posting that soon. All right, so now it's up to you. Before you begin to pack up and head out to see those families of yours, I want you to jot down 3 things that you learned in today's webinar while they're fresh and participating in the discussion on this topic over the next 2 months by responding to at least 2 of my blog posts, or maybe 3 or even 4 of them. That would be fantastic. I really want to hear from all of you and find out what's going on out there. And finally, we would love to hear from you directly, so jot down one idea that you want to learn more about in the near future and send that idea to the folks at the Integrated Training Collaborative. We have about 2 minutes for me to answer any questions that I might have missed or that you came up with. And so I'm going to turn it back over to Corey to go ahead and let me know if there are any questions that I might have missed. And as you guys are doing that, I'm going to go ahead and put up my contact slide. And I really do want to encourage you to contact me with questions or concerns outside of the blog. But then remember, get on the blog as well so that we can continue this conversation.
The questions as they came up, which I really appreciate. Certainly, if you have another question that Corey has not covered, you're welcome to post it in the chat feature. We can get to that after. And I do hope that you clearly heard what the next steps are to join the blog and get to see what Corey's writing for 4 posts to this topic. Someone asked if you could listen to this again. Absolutely. The webinars are archived, and this will be archived by tomorrow. So if you have colleagues who need to hear this information or you want to listen again, you are welcome to do that. Let's see if I've missed. I posted in chat, and please contact Dana, and we'll put her email in the chat feature one more time. Dana manages our blog, so if you need help, if you're new to blogging. So Corey, I want to thank you very much for a great informative session, and thank you all for joining us, and we will look forward